Hello and welcome to Dragon Bytes, the paediatric podcast aimed at paediatric trainees or anyone interested in child health. I'm Asim, one of the paediatric trainees here in Wales and one of the presenters for Dragon Bytes. This week we've got the first in a two-part set of episodes for you, all about the biopsychosocial model. Dragon Bytes presenters Dr. Celyn Kenny and Dr. Thomas Cromarty are joined by Dr. Max Davie, a consultant community paediatrician based in London. They're going to be discussing what the biopsychosocial model is and how we as trainees can start to apply it in our workplace. Anyway, let's get started.
So, hello everyone. You're joining myself and Tom.
Tom Cromarty, one of the other hosts here.
And we are very lucky to be joined today by Max Davie from someone who is well known throughout the RCPCH. Me and Tom have been lucky enough to know him through various conferences that we've been to and listened to him speak. So, bore da, welcome, croeso, Max.
Hello. I'm not even going to attempt the bore da. Oh no, I did. There you go. I have been to Wales a few times to know my limitations when it comes to the beautiful language. Hello, I'm Max Davies. I'm sure I'm not the sort of person that everyone will know. It's not like Camilla's come on. I'm Max Davie. I work most of the time as a consultant community paediatrician in Lambeth in South London. I have to say, on behalf of Evelina community, because I keep not mentioning my employer, and it annoys them. And I'm also the health improvement officer for the Royal College of Paediatrics and Child Health, and I've got a few other hats which maybe I'll get onto. But I'm here to talk. I'm not here really to talk about that stuff. I'm here to talk about something else.
Yeah, lovely. Well, thanks for that. So I've come across this topic that we're going to talk about a couple of times, and I think mostly through, as Celyn said, conferences and conversations with yourself. And I know it's something that you've been practicing for a while, but the biopsychosocial model or approach is something that we've come across, and I wonder if you might give a little introduction into how you came across it and how you adjusted your practice using this approach.
So I think that's how I came across it. Is quite an interesting question, actually. I mean, back in the mists of time when I was it wasn't even called ST at that point. That's how old I am. I was a SHO. I was sort of approached whether I had an interest. Somehow, somebody worked out that I was vaguely interested in mental health, and I started looking at the new mental health curriculum for pediatrics and kind of how it was all working. At that time, there was this program called Child in Mind, which was subsequently shut down, and that was a way of getting pediatricians interested in the psychosocial aspects of what they do. And the biopsychosocial model is essentially, or approach, is essentially a way of incorporating the insight that the psychosocial aspects of a child's life are important when you're thinking about why their symptoms came about, why their symptoms or difficulties are causing problems in their life, and most importantly, what you can do about it. And what's actually, I think, is really important is that this is not an attempt to kind of take you away from the deeply practical business of pediatrics into some airy-fairy psychodynamic theoretical realm where we're kind of throwing ideas around. This is a deeply practical approach, and that after a while, after I'd kind of gone past the kind of, oh wow, there's a whole new world out there, I need to understand stuff. Actually, it's the practicality of it that's allowed it to stay with me for 15, 20 years. I mean, I've been sort of, this has been kind of in my brain for that length of time. In terms of what it is, I mean, it is just it's an approach. It's a framework to structure your thoughts. I think anyone who's been in medicine or pediatrics for more than 5 minutes realizes that there are limitations to the conventional model of here's a list of symptoms and signs, here's a diagnosis, here's the management, off we go. it's not saying that model doesn't have use to it, but it doesn't give any individuality to the individual person who's there. They're just a box of symptoms and signs that you kind of work out, and it doesn't give you any opportunity to be creative around what the actual solutions for this person are going to be in their particular situation. And I think it has become more important over time, because the nature of pathology that we're seeing in pediatrics has changed quite radically in this last 15 years that I've been around. There are many more children with whose symptoms may have a medical diagnosis, but there's kind of no pathology necessarily underlying that. So a lot of the chronic pain conditions, there is a very robust diagnostic process, but there's not necessarily a pathology there, and we're a little bit shady about that sometimes. Then there's all of the stuff about the neurodevelopmental conditions that I'm sort of basically do day to day, and then there's the kind of mental health crisis, which is currently overwhelming all of the emergency departments. All of those aspects of pediatrics require you to think a little bit outside the box and a little bit in a different way, and that's what the biopsychosocial approach gives you, is just another way of thinking about problem solving for this individual family and this individual child.
And would you say that
Yeah.
really... Oh, sorry, Tom.
No, go on, Celyn.
I was just going to say, would you say that's probably the main difference between a biomedical model and a biopsychosocial model is the individuality, which brings it back to current pediatric practice at the moment. So much focus is on the individual itself and encouraging that individual child to be exactly who they want to be, while allowing that to happen.
Exactly. So I think I probably ought to go into a little bit more detail about what I actually mean by biopsychosocial. And whenever I talk about this approach, I always have the same image in my head, and it's very difficult to do on an audio. But if the listeners can just visualize a table with 3 columns and 4 rows. So the biopsychosocial is the columns. So it doesn't throw out the biological. Biology remains important in this. Psychology is the thoughts and feelings of the person. And sometimes you can ask them, but sometimes you have to deduce and kind of hypothesize how they might be feeling. And it's important, that column, because it glues the rest of it together. It glues perhaps the social stuff to the actual symptoms. So to take an example, if you have an experience of domestic violence, which is a very common experience, unfortunately, for children, the feelings of fear, the effect on the relationship to their parent and carers, the reason why that might then manifest itself in abdominal pain or behavioral problems or a crisis later on is because of the psychological effects, the trickle-down effects, the effects on the child's feelings of safety, their relationship with their, let's hypothesize that the parent who has stayed, who was the victim of domestic violence, which is the most common situation, all of those things. That's the psychological column. You don't have to be a psychologist to understand feelings. I think that's the really key message there. And the social one is basically everything about the child that is not the child. So lots of people have subdivided the social column into multiple columns, and you can do this infinitely. You can go family, school, peer group, wider society, media. All of these things can go into the social column. And it's just expresses that all of these things are important when you're looking at the child's symptoms, but also, as importantly, the effect of the symptoms or the medical condition on the child's life. Because if we're interested in pediatrics, if we're interested in children and making their lives better, we've got to be interested in that. That seems to me to be obvious. So that's the columns. The rows are the 4 Ps, and some people use 5 and whatever, but I stick with my 4. And those are predisposing. So again, we've got the biology coming back in. If someone's got a genetic predisposition to something, then that can go in. But also a lot of the stuff that may have happened in early childhood goes into predisposing. And then there's precipitating. So it may be that a bereavement or a change of school or an infection. So if you're looking particularly at, And we're going to get a lot of long COVID cases, aren't we, in paediatrics, or particularly in adolescents. So COVID would be the precipitating factor there. So it goes in, it can go into that box, but it's not the whole thing. It's not the whole picture. So that's the point. And then you've got perpetuating factors. And so this is really important. So what are the things? So once someone, let's take this person with, say, for example, long COVID, and I might be getting into deep water here, but there would be a biological insult. What are the things that are keeping the symptoms going? So is it inactivity? Is it anxiety about what might be going on? Uncertainty about diagnosis? Is it a kind of secondary gain from not being in school and being at home with a parent who's vulnerable and feeling that they are protecting that parent? Is it, is it the pain itself, making them more inactive, and or the discomfort themselves, or dizziness, or whatever it is they've got, making them more inactive, and therefore producing a kind of feedback loop? I think of the perpetuating factors as a series of vicious cycles that's trapping the child in the current predicament that they're in. And the fourth row, which is the one we always forget in medicine, just generally, is the protective factors. And the thing to ask there is, why are things not worse? So if you have this child with, kind of long COVID symptoms or whatever, the fact that they're still getting out of bed because they really love playing football with their friends, that's a positive biologically, that they have that strength and that fitness. Psychologically, the strength of their relationships, the fact that they have an uncle who picks them up and takes them to the shops on a Tuesday, little things like that, just to kind of get the strengths out. Because ultimately, with this approach, what often is the most useful thing to do is to think about the predisposing and the precipitating factors, because they're important and they're kind of how we got here. But then draw a line under them, because a lot of the problem that families have is that they have an inkling that there are things that are in the past of the family, or things that are in their, that are in the family or that have happened that are at the root of some of these things. But they feel that if they acknowledge that, they're going to be blamed for it, and that therefore it's going to be their fault, and it's going to be a kind of despairing kind of, well, this has happened to you, you're broken now, so there's nothing we can do. One of the most important things you can do is to draw a line between so it's easier when you do it visually, but between the second and third row, so between the precipitating and the perpetuating perpetuating factors, because the precipitating factors are in the past, you can't do anything about them. The perpetuating factors, so to take this example of a long COVID case, for instance, the perpetuating factors of anxiety, inactivity, in uncertainty, secondary gain, can be addressed. We can't go back and take the COVID away, but we can address those things now, and so that gives you therapeutic opportunities. And I say therapeutic in the broadest sense, in the OT, physio, chatting, talking, understanding. All of those things are therapeutic. It's not about psychotherapy necessarily, although psychotherapy is very valuable in lots of situations. And the thing we almost miss, of course, is, well, what are the protective factors? How do we boost this? How do we get you to play football more often? How do we get you to have more social contact? All of those sorts of things. How do we boost your positivity about the things that are positive in your life? And so that's the actual practical application of this in practice, is to take this particular situation and not leaving aside the biomedical model. So at the same time, you might have a validated diagnosis of something, and that's fine. And you manage that diagnosis, but this gives you all of the flavor, all of the individuality of how to deal with this situation here now for this family and this child.
Yeah, I suppose it's difficult to think that you, by addressing one thing, and whether it's a biomedical aspect, that you'll be able to sort everything else out. And it's ludicrous to think that you'd be able to change one thing and that would have an impact on everything.
No, but it's almost the founding myth of medicine, isn't it? That we will find one problem and then we'll treat it and it will get better. And it's pervasive. I mean, we all see families who want the problem sorted, who want a diagnosis so that they can move, so that they can, kind of sort stuff out. And I mean, I tend to ride with that. The main thing that I get is people who want diagnosis of autism or ADHD or something similar, so that everything can be sorted. And actually, if you dig into that, very often what they don't mean is actually, I mean, I think if you don't examine it, there is this idea that we can just sort it out by treating a condition. But if you actually dig into people's understanding, they know that that's not the case. If you make them think about it. But what you can do is then combine a diagnostic process with a biopsychosocial process and say, well, okay, this will help, but what else is going on? What else can we do to move things forward? I mean, to take the example of the sort of conditions that I diagnose, they're only ever the background to the behaviors and the emotions that are going on. And I think that's true of lots of things in terms of diagnostically, that they form the stage rather than the actual script, as it were. So I think it's a myth that we tell ourselves, and that we kind of I think we propagate to an extent to keep ourselves important, to be honest with you, as medics. But if you I think it's rare to find a family who genuinely believe it once you've actually talked it through with them. What they want is acknowledgement that it's not their fault, acknowledgement that there's something genuinely going on, and a plan to move forward. And so that's why you don't get rid of the biomedical model. You don't throw it out, because sometimes that, I think throwing out the biomedical model sometimes, for instance, in mental health services, if people don't get told a story about what's going on, they just get like suggestions for what to move forward. They go, well, they didn't know what was happening, and we still don't know what's happening. We still don't know what's going on. So being clear about the story, either through a diagnosis or through a story and an understanding of how we got here, is really vital for people to be able to move forward, because otherwise they just get confused and resentful, and then they go after someone else to get the diagnosis that they want.
So you've used long COVID as a perfect example, and a very topical for what the challenges at the moment within paediatrics.
I'm not by any means a long COVID specialist. I've just been reading quite a lot about it.
I just think it's a really good example, and brings it to the now of what challenges we may be facing in the future, especially given the current state from the pandemic. I was just wondering, I know you do a lot with chronic pain and the mental health, which you just discussed. Is there any examples that you wouldn't initially come to mind straight away that you could use this model for within paediatrics?
Well, I think the two ones that we talk about most are the sort of chronic pain conditions of any kind. So, we have all sorts of things, like abdominal migraine always strikes me as an interesting one. It gives an idea of there's a pathology going on, but do we really know that there is? Do we have actual evidence that there is a pathology? Can we test for it? It's a syndromic diagnosis, isn't it? It's sort of, you think, sounds like abdominal migraine, let's call it that. But actually, very often, it's indistinguishable from recurrent abdominal pain, and the management of recurrent abdominal pain, actually, in kind of evidence-based guidance, is essentially biopsychosocial. It's essentially looking at all of the different aspects, all of the different contexts that the child exists in, looking at anxiety, looking at all of these things. But we often don't do it. We sort of give them some peppermint essence, which is fine. Nothing wrong with peppermint essence, but or we sort of say, well, it's just one of those things. Try not to stress, and that doesn't really help. I mean, to take the example of recurrent abdominal pain, about 80% of children with recurrent abdominal pain have clinically significant anxiety, and yet we don't talk about it in those terms. If a child comes in for their third ED attendance with abdominal pain, and no one really, they've had some scans, they've had some bloods, and people don't actually think that there's a pathology going on here, we don't talk about anxiety first up. We do all the bloods again, and we kind of reassure them, try and reassure them that way, because then we feel like we've been proper doctors. But actually, if any other condition was 80% comorbid with this presentation, we would look for it. But it's partly because we're scared of mental health in paediatrics. We're scared of opening that Pandora's box that we don't. And I don't think there's any justification for it beyond that, actually.
Yeah, I suppose, do you think one of the reasons why, say, you've been kind of taking this approach for 15, 20 years and other people haven't, is that, well, I was wondering what you think the reasons are behind that. Is it because people are think those other aspects are not my job, or they're worried about going into that and then not being able to back it up with support because you're not sure what to do.
Yeah, I mean, it's one of the things I don't want to be kind of say or seen as saying that I am better than other people because I take this approach. I think to an extent, most of those last 15, 20 years I've spent in community paediatrics, and it is easier to use this approach. In fact, I think it's essential to use this approach. If you don't use this approach in community paediatrics, what on earth are you doing? So I'm critical of people who are in community and not using this approach, but in acute medicine, it's a different matter. And I think there's a few things. I think it's a messier way of going about things. And if you don't like mess, if you don't like nuance and kind of and conversations and taking a bit more time to start with, and you just want clean and accountable medicine that you can audit, then if that's what you really value about medicine, it's difficult to make that jump. And I think I did use it when I was doing acute on call, but of course I was only really doing on call. So I don't want to kind of minimize the difficulty that you have when you've got 9 patients all waiting for you to be reviewed, and you kind of have to take a biopsychosocial model with all of them. So I think there's a perception that if we open up the can of worms, we'll be there all day. I don't think that's true, but I think that that's something that people worry about, and I think there's a probably accurate perception that the initial assessment may take a bit longer if you take more of a biopsychosocial approach. I think that's probably true. It probably will take a bit longer, and I think there's also a feeling that people expect you as a doctor, particularly in acute medicine, to make a diagnosis, give them some management, and off you go. To say, well, actually, I want to talk about how you're feeling and how things are at home, rather than just make a diagnosis and off we go, it confounds expectations. And so that is an effort of will to say, well, actually, we need to talk about this as well. We can't just talk about what diagnosis and what scans you may or may not have. So I understand why people haven't. I understand why there is a spectrum of how biopsychosocial people are. But I think that one of the things, and one of the most negative feedbacks I've had from talking about this, is at a conference once when I was talking about this, and someone furiously stood up and said, "How dare you suggest that we're not doing this already? We are doing this already." And I was like, okay, fine. I'm not suggesting that people are not doing this already. I think everyone is doing a bit of this already. Everyone, nobody doesn't understand that this stuff is important. I've never spoken to anyone who says, well, this is nonsense. Of course, we should just be, mechanical diagnosis machines, and children are just, bags of symptoms. No one thinks like that. So I'm not saying that people don't think like that. It's just what this approach and this structure gives you is a framework for putting your instinct that this stuff is important into something more of a substantial kind of problem-solving machine that you can therefore add to your management, which is additional to managing whatever medical condition you think you're managing, but it allows you to just add stuff that will help this particular situation. So it's not a radical departure for most people. It refines existing intuitions and thoughts.
Yeah, because I work in emergency at the moment, and I can just see lots of the presentations, perhaps the kind of traumatic ones, minor trauma or whatever. I can see how it might not be so so needed, but still, I think you could even do that with even the smallest things like that, and you'd have some of those boxes filled out. But lots of the abdominal pain, or even parents coming in with unsettled infants or babies.
The colic. The colicky babies.
All that kind of stuff.
Does anyone actually know what colic is? Can anyone actually tell us what colic is? But we say it. We say, oh, yes, colic. Yes, definitely colic. Nobody knows what colic actually is.
Yeah.
And I just wanted to say thank you to Max, Tom and Celyn for taking their time to record that with us. That's the first part in a 2-part series. Please tune in again next week for the second half of the episode. Thank you for listening to Dragon Bytes.